Hey everybody, it's Karen Anderson here with Aortic Hope for today's very special live Q&A. Before we get started with that, I'm here to remind you to do it now. Just click like because you know you're going to like this. And don't forget to click subscribe. There's a little bell that's going to notify you every time we go live so you don't miss wonderful events like this. We have a great live event for you today, which is right before Aortic Disease Awareness Month. So this should kind of get everything flowing and get you excited about all the different things that are getting ready to happen. This is a first. We've had a chance to talk to Dr. Catarino. I was introduced to you from our mutual friend, Gareth Owens of Aortic Dissection Awareness UK and Ireland. That is a mouthful, but he is a wonderful person and they have a wonderful organization. So I'm going to hand this off to you and let you take a few minutes to tell everybody who you are and where you are now here in the States. But thank you so much for joining us, Dr. Catarino.
Thank you for that lovely introduction. So my name's Pedro Catarino. I'm a cardiac surgeon, and I'm the director of aortic surgery at the excuse me, Schmidt Heart Institute at Cedars-Sinai in Los Angeles, where I've been working for the last 4 years. Thank you very much for having me today, and thank you for the fantastic work that you've done with your patient information and patient guidance booklets, which I use with all my patients here in Los Angeles. So thank you very
That's
much for that.
wonderful. Well, that again, credit to the UK and Ireland, although I don't know if you realize we are in the process now, almost ready for a clinical review of aortic disease, the patient guide. So that's another exciting follow-up to this. We will
Fantastic.
get those to you. We'll ship them out.
So today I was hoping that I would answer some questions that you have, and
Yeah.
I very much took it as if I might be seeing a patient in clinic, and the sort of questions that a patient would have, and that what I would say to them. So let's see what you have to ask.
That's perfect. All right. So first of all, many people, if they have a dissection or they're diagnosed with an aneurysm, their first question is, what's an aorta? So let's talk a little bit about the aorta, because I do have a specific question about that in a minute. So let's get into what is an aorta.
Okay, so the aorta is the most important blood vessel in your body, and it supplies all the branches that go to all your organs except for your lungs. But so it comes straight out of the heart here at the front of the chest. It goes up the front of your chest. We call that the ascending aorta, and then it arches to your back, and it goes all the way down your back, and about the level of your belly button, goes into the abdomen. At the belly button, it splits to give the arteries to the pelvis and the legs. So it really is a very long blood vessel, very important. And because we're upright creatures, we have to supply blood to our brain. It has to carry blood with a certain pressure in it. So it has systemic arterial pressure in it, which is that number that you measure in your arm when you measure your blood pressure. And the top number, say 120, maybe more if you've got a bit of hypertension, that's the pressure when the heart pushes, it ejects. And then the bottom number is the pressure when the heart relaxes. And but that's the pressure that is in your aorta at any moment.
And what is typically the size, the normal size of an aorta, diameter-wise?
Yeah, so it's not exactly like a garden hose that is tubular and the same diameter all the way along. Because it gives branches all the way, it's widest at the beginning, the bit that comes straight out of the heart, the aortic root. And we typically measure it in centimeters, so around 3 centimeters, 3.2 centimeters in the aortic root. But obviously varies with the size of the patient. It varies between men and ladies, and then it narrows as it goes along because it gives off branches. It doesn't have to carry the same amount of flow once it's given off a branch. But the important thing, I think, for everybody to realize is that 3 and a bit centimeters is the maximum normal diameter. And so once your aorta hits 4 centimeters, 4.0 centimeters, we think of that as abnormal, and we call that an aneurysm.
Okay. Now, it was just announced that it's its own organ, and everybody got excited. I didn't understand why. So what is it about that everybody's now calling the aorta its own organ? I understand the zones and how understanding the different areas specified on the aorta would impact treatment or follow-up diagnosis, monitoring, what have you. But what does it mean when they call it its own organ?
Well, I think that reflects the importance that we place on the aorta as having its own pathologies, its own diseases, and so its own interventions that are separate from having heart disease or having a stroke or something like that. So I think that's why we've emphasized it as its own organ.
Hmm.
It has its own blood supply, it has its own nerve supply, and it works in conjunction with your heart and the rest of your circulatory system to keep your body well perfused and to keep your blood pressure relatively constant and to respond to increases in demand for blood flow, such as exercise or special efforts. So in that way, it is very much a separate organ.
It definitely makes it as important as we make it out to be. Would you believe this, that my charger, my plug came undone? So give me one split second. I can't believe this has never happened. So now I'm trying to figure out where it went to so I can plug it in. Oh, there it is. I found it. Sorry. I feel like there should be a musical interlude right now as I do this. There we go. All is right in the world. Okay. All right. So we know that aortic dissections are rare, but aortic disease is much more common than we think. And that's really what Think Aorta is driven on, is the fact that aortic disease is so much more common. But we want to back up just a little bit and we talk about aneurysms because we want to try to avoid the dissection. So let's talk about the process in which somebody would actually have an aneurysm diagnosed.
Yeah, so probably the most important thing to realize about aneurysms is that they very seldom cause symptoms.
Hmm.
So mostly we pick up aneurysms because people have an imaging test for something else. And rarely we pick it up because they have a family member who knows they have an aneurysm or they had a dissection, and so they have imaging for that. So for many patients, it's a surprise. They've gone in to have an X-ray because they had a cough, and now they're being, they're coming to see me when they're told they've got an aneurysm in the
Right.
aorta. So it can be a little bit of a shock. But I
Hmm.
would say that the great majority of patients with aneurysms, we don't immediately rush in and do surgery. We monitor them because we know that there is some leeway where the risks of intervention outweigh the benefits. And,
Right.
during that period, we're happy to put the patients in what we call a surveillance program, where we just monitor the size of the aorta sort of year on year.
Right. And that's the watchful waiting or the anxiety ridden time period for all of us that are out here. And okay, so I'm going to end up going out of order of what I wanted to ask. But some people, when they find out they have an aneurysm or dilations, because these various doctors throw around different terminology, will say, I was told it's 4.2 centimeters last year, but this year it's 4.3. I can't believe it grew. And I sometimes am just too tired to address it, but I know that I would be asking, was the test done at the exact same place in the same machine, same person reading it? Was it a gated CT? Can you explain the little subtle differences that could cause that 1 millimeter difference, and also explain how that is or isn't considered true growth?
Yeah, those are excellent questions, really. And of course, the modality of the imaging. So patients come, sometimes they've had an echo image, sometimes they've had a CT scan image, sometimes they've had an MRI image, and all of those measure slightly different things. At a very basic level, the echo image is very operator dependent. It depends on where the operator puts the probe and angles the probe, and it measures the inside of the aorta on one side to the inside on the other side. So you can see immediately that's going to be a different measurement from CT
Right.
scan, where it slices through the body, like this, and
Uh-huh.
where the measurement is from the outside wall to the outside wall. And even with the CT, I mentioned how important the observer was for the echo. For the CT, it's also important because the aorta isn't, I said it came straight up the chest. It doesn't come straight up, it's at an angle. And so when we slice it like this, we're cutting it obliquely. And it
Hmm.
is important for the radiologist who's reading the scan to be able to, they have a software where they can tilt the aorta and really cut it perpendicular and measure it as accurately as possible. Even when they do that, we allow for up to 2 millimeters difference in readings between professional radiologists who do this for a living. You also mentioned gating, and
Mm-hmm.
the aorta is constantly moving. And if you go and have a standard CT scan, say for your lungs, they often don't gate the image, and they may not even put contrast into the aortic lumen. And so the aorta is moving like this, and when the CT scan takes the picture, it takes the picture and it includes the movement from one side to the other side.
Which is going to make it appear larger.
Exactly. It makes a bigger shadow. So it is very important. Gating allows us to do a sort of instantaneous picture. But even with gating, there's a prospective gating, which is the most accurate, and there's retrospective gating, which is slightly less accurate. So it is important to have the same type of test read by the same doctor, year on year. And that's where a lot of patients come and they are a bit anxious about it. They say, well, why don't I have a scan in 6 months or even 3 months' time? And we try and avoid that. We really try and do the scans every year, because if you do get a measurement in 6 months that's the same, that may be falsely reassuring. The aorta does grow very slowly. So we try to, have patients have images, once a year, have that sort of anniversary scan.
So great. On our aortiversary, we have scanxiety. That works. Well, let me ask you, do you think it's fair, at least for myself, not to discount radiologists and them reading and coming up with a measurement? I have personally felt that I wait until my surgeon pulls it up on his screen and does his exact same way of measuring. Every time he does it, he picks the spot, he measures it, and then he's the one that says to me, nothing, we'll see you again in another year. Or he'll say, well, he hasn't yet, but he will one day say to me, okay, it's time for us to have a conversation. So do you think that's fair? Because patients will run out to get those results. They don't even wait, a lot of people, for their physician to call. Is it one of those things that really just let your physician be the final say, since they're going to be the one to potentially do surgery or intervention?
Yes, I think so. And that's because you can't guarantee that the radiologist was the same radiologist each year, and they change slightly what they report from time to time. With them, I sort of describe the aorta as a tube, but in the root, it's more like a little clover. And sometimes they report the distance between the leaves of the clover, and sometimes they go from what we call the commissure across to the clover. So I would really encourage patients not to read too much into the radiologist report that may come up on their phone app, straight after the imaging. Really go on your surgeon or your cardiologist, who's looking at the scans with you next to them. And usually when I look at the scans, I know the radiologist has got a very fancy workstation where they can manipulate the pictures very much. So I look at it and I make my measurements. And then I go and look at what did the radiologist report. And that's like my conscience to check that I have done it properly and I haven't missed something that they've measured. And if it's very different, I want to really understand why they've measured it differently.
So there's nuances between the different areas of the aorta. There's some organizations that only focus on thoracic ascending aortic disease, and then some that would include descending. We happen to be inclusive of everyone, whether it's thoracic or abdominal. But let's talk about these different locations. So is it safe to say, because I'm really interested in this, for instance, my father had an abdominal, I ended up having a thoracic ascending dissection. If you have a thoracic ascending aneurysm, are you in the clear? You don't ever have to worry about the abdominal? Or what if it's vice versa? I mean, is there a higher likelihood that you will develop it in another area of this one vessel? Or can the vessel really tell its own different locations and say, no, you will not have one here? How does that typically work?
Yeah, so it's very interesting. And I think what you said reflects some of the history of how this has evolved, because most thoracic, so in the chest, aortic aneurysms are due to some subtle weakness in the aortic wall that results in the aneurysm. And if you looked at the inside of the aorta, it's pristine, it's clean, it's beautiful, healthy, intima. Whereas in the abdominal aorta, it's a very different pathology that results in the aneurysms. It's typically atherosclerosis, which is the same condition that causes furring up of the heart arteries or the arteries to your brain.
Okay.
And the inside of the aorta is really damaged, and that results in the aneurysm forming. So historically, we've always thought, well, there are these two distinct pathologies and we don't need to overlap very much between them. But actually, as time's gone on, we realize how often patients who have a weakness in the aortic wall that causes a thoracic aneurysm, how often that also results in an abdominal aneurysm. It's actually about 10% of patients who have a thoracic aneurysm will also have an abdominal aortic aneurysm.
Interesting.
And I'm sure as we end up understanding more about the genetic predispositions to these aneurysms, we'll understand better who needs screening of the full aorta and who can focus on thoracic or abdominal.
So this just popped into my head because that happens. I often have wondered, I know women are more likely to develop a SCAD or a spontaneous coronary artery dissection. And I have to wonder if they had that happen, is it a guarantee that they'll never see anything in a much larger artery, such as the aorta? Or is it truly in this particular case, and it could be in other cases, specifically just limited to the coronary artery? I don't know anything, but in my imagination, which I have a good imagination, like many community members would think, how do these different vessels differentiate from one another? I would want to just have everything checked out to make sure, especially when it comes to the largest artery, I'd want to make sure that everything looked stable.
Yes. So it's very interesting that you brought that up, because at Cedars we have a very strong Women's Heart Institute, a very strong program that investigates and treats patients with SCAD. And we've worked together to try and figure out if there's an overlap between SCAD and aortic diseases, specifically aneurysms and dissection. We haven't really found much overlap. I think SCAD is still very rare condition, and it happens in younger ladies, and so there isn't a big overlap. But I mean, it stands to reason that whatever is making up the wall of the coronary arteries that's susceptible to a coronary dissection is also present in parts of the aortic wall and could influence that. The coronary arteries are very much smaller than the aorta. So we're talking about vessels that are 10 millimeters in diameter at the biggest part, at their origin, and then they taper down to 2, even 1 millimeter. So they're really fine vessels. Whereas the aorta is a sort of 2.5 to 3.5 centimeter vessel. It's subject to different wall stresses.
Okay. So we're talking all about aneurysms here. We're getting started in there. And all things considered, if a person does not have any kind of known family history, doesn't have a known connective tissue disorder or a symptom, what would be some of the treatment plans for that person if they have an aneurysm? And then what would be some of the more invasive treatment plans? So if somebody doesn't have anything known in their family history, but they come to you with a 4.6, and versus somebody who they know they have Marfan's, or their family member had Marfan's, they have, for whatever reason, they're not yet genetically tested, or somebody else in the family has something, but they don't know what it is. Nobody knows what it is. Are there different treatment plans, and how do you handle both of those different scenarios?
Yeah. So let's take the person who doesn't have any family history. They've got no inkling that there's any aortic problem, and they've had a scan that shows a 4.6 centimeter aneurysm. So, when I see them, obviously the family history questionnaire is important, but also I want to know about their blood pressure history, and also whether they do a lot of exertion or under a lot of stress. So the family history thing is about the strength of the wall of the aorta, but there's also the pressure inside the aorta that's also tending to make to cause the aneurysm. And so if they don't have family history, I want to see, well, do they have a pressure reason for having for getting an aneurysm? And essentially at 4.6, I'm very unlikely to recommend intervention, whatever their age. So even you think of a very young person, say like yourself, that's got many years that they have to get through. That it may be that the aorta never enlarges from the 4.6. So I'm most likely to put that patient into our surveillance program, which involves annual scans. But also I'm going to give them some lifestyle advice. And the main lifestyle advice is going to be around their blood pressure. So first I want them to monitor the blood pressure. They don't have to be neurotic about it. They can measure their blood pressure once every 2 weeks. Right. And I say, next time you come to see me in the clinic, I want a diary with 26 blood pressure readings, which is your readings once every 2 weeks. And what I'm interested in is that sort of average chronic blood pressure. And ideally, I'd like to keep it below 130/90. That does depend a little on age. If they're older, I'm going to relax those criteria. And then they always ask me about exertion.
Yes.
And mostly they've been told not to lift very heavy items. And actually, over the years, I've relaxed the way I think about this. And I usually tell them that aerobic exercise, they can do whatever they want. And they can put their heart rate up to whatever they want. And I justify that on the fact that I'm most interested in the average blood pressure over time. And even though their blood pressure is going to be higher while they do the aerobic exercise, on average, the aerobic exercise will help them drop their blood pressure.
Right.
And then as far as the weightlifting, I don't want them to do anything where it is a sort of very strong isometric exercise where they're lifting one weight. I often say, don't lift the piano or don't go to the gym and lift weights that you can only lift once or twice. Right. If you can go to the gym and you can do weights that you can do 8 reps of that weight, then I'm happy with that.
Right.
So that's how I try and set it, not to give them like a 20-pound limit or a 40-pound limit or something like that, which is quite hard to live by. And your own body is more than, 150, 200 pounds. Right. And when you do exertion against your body weight, you're going to easily go beyond those sort of artificial weights that we sometimes set our patients.
Exactly. It's funny. My mother just said to me the other day, I took a 12-pack or 24, I can't remember, of water out of her trunk and just brought it into the garage. And she yelled at me. And I said, the entire time I was breathing, I never once bared down. So, and I've also figured when we all go away, I have to get my suitcase out of the trunk. My husband's not there. So if I can be breathing out as I pull that 40-pound 2-day suitcase full of clothes out of the trunk, then I know I'm okay. I would think that it would be more of a problem if I've got to grunt and I'm bearing down. And plus, I'm not walking around carrying the suitcase over my head. I'm just taking it out of a trunk. So I like what you're saying about that. It was one of the things I had to tell my son after my dissection. He had just started in high school weight training at 16. How do you tell a boy, no, you're not looking to leg press 400 pounds? But I did have to explain to him, you will get the same results with less weight and more reps. It's not about how heavy everybody can do one. What's one? It's about how long you can sustain at the lower number. So, I had to sneak behind his back and tell the gym teacher that.
I liked your point about the lifting the weight above your head, because I tell patients when they go on the aeroplane to be careful about that, lifting a very heavy piece of luggage up into the overhead compartment and to get one of their fellow passengers to do it.
You are right there, because there have been times where I've packed everything into the carry-on and you go to lift it. And I know there's no way possible I'm going to be able to do that without actually bearing down. I can already feel it. So I do get assistance from people. And that is, I think, a really good visual for people to understand the difference. But you are totally okay with somebody whose lifestyle might have been doing marathons and being extremely active before, if this happens, a lot of those people, there's a whole, Facebook page for people that love to remain that active. It's so important to them to have that normalcy and have that activity level. And what we've been telling people is then you need to build that into your health plan with your physician and figure out where your target numbers are for your heart rate and recovery of your blood pressure. Would you agree with something like that?
Yes,
Hmm.
absolutely. And so that
Okay.
patient who came to see me at the 4.6, and I said,
Uh-huh.
okay, I'll see you again in a year's time. I'd like them to carry on with their activities so that
Right.
I can factor that into, well, the aorta's stable,
Yeah.
but you carried on with your normal lifestyle versus the aorta's stable, but you've not been doing anything.
Yeah.
So it is important for us also to understand, if the patient is changing their lifestyle dramatically.
Now, if this 4.6 has a known condition or family member has Marfan or has VEDS or something like that, I would think that the threshold might be potentially a little bit different. Or if their aortic valve is bicuspid and they're symptomatic, maybe things might be different.
I have to say, I give a lot of weight to family history.
Hmm.
And a patient who is young and has a 4.6 and a family history, particularly if they had a family history of dissection, I would be thinking about operating on them. It's not urgent, but
Right.
I would be thinking that this person isn't going to get through their life without needing an operation. And so why um, subject them to some years of surveillance,
Hmm.
which is carries a risk in itself, when they could have their intervention now and prevent all that risk during the surveillance.
Right.
So even though 4.6 is mostly below the guidelines that from the various academic societies,
Hmm.
somebody who had a family history of dissection, I'd be really thinking and counseling the patient towards an intervention.
Right. Okay. How often are you seeing patients who received a diagnosis of an aneurysm and they're in their watchful waiting, but they end up having a dissection before their scheduled surgery? And if you see that, what are typically the reasons for that? And that's a very hot button. People are always asking, what do I need to look for? Because it never fails that somebody finds out they have an aneurysm and all of a sudden they have shortness of breath overnight, they have chest pain, they can't swallow, their food's getting, and I'm thinking, this could have been in you the last 20 years, and now you have your diagnosis and you're
Yeah.
very symptomatic. I'm not going to take away that because we know mentally and emotionally can bring on a lot of physical changes. But what, when have you seen that, and under what scenario would somebody potentially diagnose before that surgery date?
Yes. I mean, fortunately, the patients that we have in surveillance haven't presented
Oh, that's
in
great. Yeah.
extremis. We give them all, they have cards, so they know what their symptoms to get and that they should go straight to the ED. And that,
Hmm.
that I think one of the issues is in diagnosis. So, the ED may not realize that the patient has an aortic aneurysm and that
Yeah.
aortic dissection is very high on the differential. So it's
Hmm.
important that they communicate, that they go quickly to the ED and they communicate that straight away.
Right.
I have seen patients who have had dissection and have been followed in other clinics, and the reality is that more than half of dissections occur below the threshold at which we advise
Right.
intervention. But if we were intervening on everybody at those low levels, we'd be doing an awful lot of unnecessary operations. So that's why
Right.
it's every patient is an individual discussion about those
Hmm.
risks and benefits and the patient's own threshold for surgery
Hmm.
and to some extent their threshold for how they're able to carry on with their life, putting the aneurysm out of their head. If
Yeah.
they can't put the 4.6 centimeter aneurysm out of their head and that's all they can think about, they should have surgery.
Right.
So
Okay,
it
I'll be
it
giving you
really
a call
varies from
tomorrow.
patient to patient.
I'll give you a call tomorrow. No, I've been living with a dissection and two aneurysms at about 4.7. One's at the root, one's descending, and my valve isn't doing great. But boy, I'm told every year we're not ready yet. And so it's tough, but I understand the pros and cons and the risk. This is her second surgery, and this is even though I want one planned versus emergency, and I'm not looking for it to have to happen because I know what it's going to be like when it happens. But there's also a peace of mind element that if I knew it was scheduled and I knew it was going to happen, I could have everything in place versus when it was an emergency. So I think it's a hard decision for patients. We wrestle with that just as much as the physicians wrestle with when is the better time.
Yeah. And we have an increasing amount of data for patients who have never had surgery, the
Yeah.
primary presentation. But we have not so much data of patients in your situation who've had previous surgery.
Yeah.
And most likely the thresholds are different, and they
Hmm.
should be higher because the risk of the intervention is greater. But also, I think that the native tissue behaves differently once it's been operated on, and it's not as risky to be at 4.7 when you've been operated on before as it is to be at 4.7 when you're a primary.
Right. Right. So before we continue any further, I know that you told me you had a photo or a video, and we have an opportunity here to see an actual almost between 6 and 7 centimeter aneurysm. So I want to warn everybody, trigger warning. This is your time to just kind of look away, go get a glass of water, do whatever you need to do for a few minutes, because it really, at least I told you, I find it very fascinating, and I think it gives a very interesting perspective to have that opportunity to see that. So I'm going to let you go ahead and put
Okay,
that on.
I'm gonna share my
Okay, it's
uh,
coming.
and hopefully that will play.
Yeah, that would be
So
great.
this is the aorta, and you can see there's a little ruler across the aorta, and you can see the heart. It's covered a bit of fat on the heart, the yellow stuff, but the heart's beating away, and you can see that this is abnormal tissue. You don't have to be a medical expert, and the blood vessels that are supply the aorta itself are stretched. And then you can see here, once it gives its first branch, we call the innominate artery, it comes back to a normal size. So this is the size the aorta should be,
Wow.
and this is really a massive aneurysm. So
It's
let me,
massive.
so that
Can you
definitely
imagine
needs
being the
surgery.
radiologist who's giving somebody an echo and you see that? I can't even imagine what the face on that person looks like. But, the likelihood of just finding that out of nowhere is probably slim too. So they've probably been watching this, but I think that's just unbelievable.
Yeah.
I know somebody in the community who just was feeling off. She was very young, about 25, and was very active, but something wasn't sitting right with her. She knew something was wrong, but couldn't pinpoint it. And after having lots of tests, none of which included an echo or a CT, they wanted her to start psych meds because they thought everything was in her head. And she said, Can you just give me a chest CT? So let's just do one more test." And when they did it, they almost didn't let her go because she, at like 100-pound build, 25-year-old woman, had a bicuspid valve and had that in her chest. She had
Well,
a seven
look at
centimeter.
how
It's
much
like
space that occupies. That
incredible.
occupies a big amount of space. If you had
Yeah.
that in your chest, you could imagine that that would give you
Yes.
symptoms
Right.
that were not the sort of typical symptoms of
Yeah.
cardiovascular disease.
That's amazing. Thank you
Can
for sharing
I
that.
want to show you something
Please.
else with
Yeah.
this. This is just a very simple vinyl glove, and it allows me to bring up a principle of aneurysms, which is very important to the way we think about them. So I'm going to blow the glove up. And so the pressure in the glove and the fingers is the same.
Mm-hmm.
And I'm told the gloves are very well made, that the wall thickness is the same. So the bigger the diameter of the vessel, the higher the wall tension. And you can see when I squeeze the fingers, you can see that the wall tension is not very high. Even the thumb, the
Mm-hmm.
wall tension is not very high. When I squeeze the body of the hand of the glove, the wall tension is much higher. And you can try this at home,
Mm-hmm.
with just to emphasize to yourself that as the diameter gets bigger, that really affects the wall tension. And
Yeah.
it's the wall tension which is going to result in a tear, like a dissection. And like many things in biology, it's an exponential process. So the difference between 4 and 4.5 is a certain amount, but the
Mm-hmm.
difference between 4.5 and 5 is quite a bit bigger. And then
Right.
between 5 and 5.5 is, it's a,
Yeah.
so I say that in a way to reassure people who are at the smaller dimensions that their risk is not so enormous that they have to be um, overly anxious about it.
Right. That makes sense. And now you've just led us right into the dissection world, which was great. I love that. I haven't seen anybody do that with the glove, but that makes so much sense. And I suppose if you increase the pressure right into any one of those fingers by squeezing it, you will see how much more that glove, the outside of the glove, is stretching. It's the same thing if you do it with a balloon, and then it starts to become thin and gets that white sheen like it's going to pop. It's amazing. Joshua, I just want to check in with you and see who's on with us right now before we move into the next section.
Oh, we have some questions coming in right now.
Oh, so we'll answer some questions.
Yeah, let's see if these are closely on topic here.
Okay.
And I will say hi to everyone first. Christina, Melissa, LM thank you for visiting with us today. Josie, Thomas, Nina, and George Horton.
Okay.
Did I say
Hello,
Melissa?
everyone.
I meant to say Melissa.
You did say Melissa.
Okay, so forgive me if I ruin your name, sir or ma'am. Vijayalakshmi Nagaraj has asked, how safe is it to have an MRI post-TEVAR procedure? I know most people recommend not doing MRN within 6 months, but can you have an MRI in 2 years?
Yes. All these all these modern TEVARs are now made that they're MRI compatible. Yep, so you could go ahead and have the MRI. It'll be safe.
Nice and succinct. We like that. As you guys were covering the watch and wait recommendation, Nina said, that's exactly what my doctor said. And Melissa also said, nice to know that Dr. Catarino is so close and his colleagues are people that I have met 14 years later in the surveillance mode, and to know that treatment is still suggested. So again, watch and wait, still very good. George Horton had a question. Northwestern recently found that aortic wall flutter was predictive of future events with a 98% accuracy. This was done with a 4D MRI. Is this being done at Cedars?
Yes, no, that's a very sophisticated measurement of aortic wall sort of compliance, and it's not part of a routine MRI. We do some flow measurements to try and measure wall stresses with MRI, but we haven't got software really that looks at that sort of the wall compliance itself. I'm very hopeful that that research will be disseminated and that we'll have a better understanding and more precise indications about when to intervene.
All right. Thank you so much, Doctor. You're doing great.
Okay. We're moving on to the next section. All right. So dissection. So as we know, September used to be Aortic Dissection Awareness Month, and now it's Aortic Disease Awareness Month. What would be some of the different treatment options depending on the type of dissection that one would have?
Okay, well, we have a simple classification for dissection we've had for many years. We've got type A's and type B's. And type A's are when they affect the ascending aorta. And so if you have blood outside the lumen in the ascending aorta, it's a type A. And anything else is a type B. So that includes the arch, the descending. Doesn't really matter where the initial tear is. It really matters if you've got blood outside the lumen. So type A's are emergencies because this part of the aorta, it receives the full pulse of the heart, and so it's susceptible to rupturing. So you need to have surgery immediately. And even if it doesn't rupture outwards, it can rupture towards the heart, and that would compress the heart, and so would be fatal. Type B's, because you're a bit further along the aorta, so the pulse is less, and also you have branches. So the arch, there are 3 big branches to the arms and brain, and as you go around the aorta, there are even more branches. There's some runoff for the blood to go, and so there's less risk of that immediate rupture. And so mostly type B's, we manage those conservatively, carefully looking for some factors which could predict rupture, in which case then we could intervene. And mostly type B's are managed with if they need an intervention, they're managed with a stent, so TEVAR, and almost invariably type A's are managed with open heart surgery.
Now you had another show and tell.
So yeah, so I have a device here which is part graft and part stent. So if you're getting a stent, you get just this part. It comes collapsed, and the material of it is the same. It's a type of polyester, sort of medical grade polyester, very carefully woven. And in the stent portion, there are metal rings, a type of steel, often with an alloy in it, which allows it to get its shape when it reaches a body temperature. And the stents come collapsed, and so they can go in through a small artery, and then they reach the part of the aorta that's needed, and then they're allowed to expand, and they support the wall of the aorta. And then when we do open surgery, we use the graft. So this is the medical grade polyester portion, and this is what we use to replace a segment of aorta that could be dissected or ruptured or indeed have an aneurysm. And so at one end, we have to sew it to good quality tissue at this end, and then at the other end, we sew it to good quality tissue. Now, sometimes this is a very special graft. You can see it's also got some branches. So it looks very much like the ascending aorta, the arch with the 3 branches of the arch to the arms and brain, and then the stent which fits down the descending aorta. And so this is a type of device which allows us to bridge between the ascending aorta into the descending, and brings the benefits of both open surgery and endovascular surgery, so stenting. And it's particularly useful for dissection, where the dissection typically occurs in the ascending, but it goes all the way around the body. So the whole aorta gets dissected, even into the leg arteries, and it would be impossible to replace all of that aorta. So traditionally, what surgeons have done is just replace the ascending aorta. And so that usually deals with the initial tear in the wall of the aorta that blood got into. With the dissection, you end up with these 2 channels, the true channel and the false channel. And we always really thought that by replacing the ascending aorta, we would push all the blood in the true channel, and that would force the false channel closed. Actually, it doesn't. In most cases of type A dissection, that doesn't happen.
Okay.
You keep that false channel, and then you need to have surveillance and monitoring of that false channel. And so a surgery that's a little bit more extensive, that includes the arch and reimplanting the branches of the arch, and then this stent in the descending, that's much more successful in obliterating this false channel that you get in a type A dissection. And so the long-term results are better with this sort of new device, which was only FDA approved a couple of years ago. So it is a treatment that we are getting to understand better, and is mostly used in.
What that looked like to me was like a 12-hour surgery. That's all what that looked like to me, if not longer.
Yes.
That's amazing, because I don't think they had that back in 2015, because
No.
I'm one of the old school, have the Dacon graft for the type A and watch the rest of it.
The rest. That's right. So this really came in 2022.
Okay.
But for one of the big parts of having type A dissection surgery is that you're connected to the heart-lung machine, and your body is cooled down substantially to room temperature or lower. And the reason you cool it down is because for a brief moment, to do the far part of the join of this graft, you have to interrupt the blood flow to the brain and the body. And so you need to cool the patient down to buy yourself a safety margin of time to do that join. Amazing. And then, so of course, you cool the patient down, you have to warm them up as well. So the length of the surgery is really determined by the time it takes to cool someone down and then warm them back up. So with this more extensive operation, in terms of there's more surgery, but it's still done in the same amount of time because of this cooling and warming issue.
Right. That's amazing. But that's really cool. I've never seen that before. So I love when I get a chance to learn something new
Right.
from all of these events. All right, let's move into aortic valves here a little bit. I know we've just gone kind of traveled backwards and in a different direction again. Um, some of the common terminologies that we've heard, other than bicuspid valve, which we'll talk about, is regurgitation and stenosis. So let's just talk about high level, or not high level, low level, easy to understand when it comes to aortic valve disease.
Okay, so easy. Stenosis is narrowing of the valve. So that's where the valve is, it's usually wear and tear on the valve, and it gets calcium deposited and scarred, and it makes a narrowing in the aorta. So now the heart has to pump much more forcefully to pump past this narrowing.
Okay.
And we actually measure the pressure in the heart, and we measure the pressure in the aorta, and we know what the pressure drop from the heart to the aorta is. We call that the gradient. So if you know somebody with aortic stenosis, they typically know what their gradient is. And so let's say you have a gradient of 40 millimeters of mercury. So that means if your aortic blood pressure is 120, that means your heart had to generate 160 millimeters of mercury to get that 120. It lost 40 across the narrowing.
Yeah.
And as the narrowing gets tighter, the gradient gets higher, and the heart has to do more work. And that's the problem. You know, the heart is a muscle, it gets bigger, like any muscle doing extra work, but that isn't good for the heart because it's got to balance its own blood supply. And so when your gradient reaches a certain level, particularly if you get symptoms, then you end up needing to have a valve replacement.
Okay.
And the other issue is the regurgitation. So that's where the valve leaks. And leakage is less often due to wear and tear, and more commonly due to other issues. For example, aneurysms can cause a leak on the valve. Infection on the valve can cause a leak, and there are some conditions that can cause a leak. And with a leak, the heart has to do extra work. You can think if it pumps, 70 mils forward and then 30 mils comes back, that's nearly 50% regurgitant fraction. The heart's got to do 50% extra work. And what happens is that to do that, the heart muscle dilates. Actually, the cavity dilates so that there's more volume in the heart. We call that a volume overloaded heart. And for a certain amount of time, our hearts are very good at compensating for the leaks. But after a certain level, and we know that that's when it's stretched beyond a certain size, then we know that the heart is close to decompensating. And that's when your cardiologist will say to you, look, now you need an intervention and replace the valve.
I'm waiting for that call. Okay. Do you want to briefly explain the difference between mechanical and non-mechanical and your options and pros and cons?
Yes. So a mechanical valve is made of carbon fiber, and they typically have two leaflets that open and close like that, and it's very durable. A carbon fiber valve will last 100 years, but it's not so friendly on the bloodstream. And so if you have one of these mechanical valves, you have to take blood thinners, and those blood thinners, you have to take a tablet every day. And the level of blood thinning can fluctuate. So you also need blood tests to check that you've got the right level of blood thinning.
Right.
But it's a very good option for young people who need a lifetime of having the valve working, and they don't want another operation.
And you can't do that endovascular, right? Because that mechanical won't collapse.
Correct. There's currently no mechanical option. There are people working on mechanical, or let's say non-biological options for transcatheter valves. These mechanical valves, they make a very slight ticking noise, like a clock, and you wouldn't hear it normally, but if everybody was silent in the room and you concentrated, you could hear the patient that had a mechanical valve. So I find that something important to warn patients about, because it can be a bit tedious for them.
Yeah.
The alternative to a mechanical valve is a tissue valve, and there are various different options. Most people have heard of pig valves. Pig valves are actually the leaflets from a pig's valve that are they're put onto a stent to make a tissue valve. They're not usually, well, they're 3 leaflets, but they're not all taken from one pig, because the pig's anatomy is such that one of the leaflets has got a big bit of muscle in it that doesn't work very well when we put it into an artificial setting. So most of the tissue valves are actually from cow material. They're not cow valve. They're from the pericardium of the cow, which is the lining around the heart of a cow, and that makes very good material that can be manipulated and made into a tissue valve, also with 3 leaflets, and that can be mounted on a sewing ring, a stent, and that sewing ring is often made of the same material as I showed you with this graft. It's a type of polyester, and that's for the surgeon to sew in open, or those cow valves can be collapsed, much as on the stent, and so they can be put in through an artery in the leg, taken around into the position of where the valve is, and blown up endovascularly or transcatheter. So those are the TAVI valves that you might have heard of, transcatheter valves.
But they last how long?
So we're not sure with the transcatheter valves. Probably their durability is as good as the surgically implanted valve. And mostly we would say to patients over the age of about 60 that a tissue valve would last them 15 years, 15. And that's pretty reliable, that the 85% of those patients would get to 15 years. Well, if you're younger than 60, you tend to use the valve up. You cause a bit more wear and tear on the valve. So it usually those younger patients, I tell them maybe 12 years rather than the 15 years.
Okay.
Of course, I'm hopeful it'll last a bit longer than the 15 years.
And what happens when you need a new one? You can just put one over top of it, or you have an open surgery, or what happens if you choose that?
So it depends on the reason for which you need the new valve. So for example, if a valve's infected, that's a serious problem, and almost always you need open surgery to deal with an infected valve. You need to take the infection away and then replace the damaged tissue. But if the valve has just deteriorated from wear and tear, we call that structural valve deterioration, then any option is possible. For example, if you've had a surgical valve, you can have a transcatheter valve put inside that surgical valve. So long as the valve was big enough to start with. So if you had a very small valve to start with, it might be challenging to put another valve on the inside. So we're very aware of this issue. We try and put as large a valve in the first time. And if you have a transcatheter valve the first time, they're also trying to put the biggest valve they can put in. And then you can have a second transcatheter valve inside the first transcatheter valve.
But no blood tests and no ticking.
That's correct, yeah.
So there's pluses and minuses. A very personal decision. I've been weighing them for quite some time as I wait till my number's called. All right. This last section because I know we're almost rounding up to our hour here before we take our final questions. This is really about mental health. This is a subject that's not addressed enough in the community from the moment of diagnosis or waking up after a dissection. I think that there are a lot of cases where patients say that that they are told after their first appointment, go live your life. We're good. I'll see you in a year. But the majority of these people do not know what that means. They are so still in shock, trying to feel their body, understand their limitations. Physically, all of us feel exhausted. We're not used to the medications. We don't think how we're ever going to work again, how we're ever going to live our life. How can we do anything? And so there's a great deal of potential PTSD that we're finding. Anything that Cedars-Sinai is doing to address these issues for your surgical patients or the watch and wait category?
So I think the biggest impact on this area has actually come from people like you, from Aortic Hope and groups of patient support groups. And so we connect our patients with groups like yourself. And we have the very close links with the Marfan Foundation. So if they have any connective tissue disorder, they're connected to the Marfan Foundation. And we really try to educate patients as much as possible about their condition, so that they get their education and information from us, not from having had to go and Google it and maybe get a slightly skewed idea of what their particular issues are. And so, we'll explain to them what we're worried about, and, what we want them to report to us as far as the symptoms and signs that they might develop over the next year. But mostly we're trying to reassure them that they're okay, that if they've had surgery, that's been effective and that's really substantially improved their prognosis, and that they can go on and go back to work and go back to the sort of lifestyle they were living before. But we are very aware of it. I mean, a number of studies have now have shown this anxiety and PTSD issue in patients who have, I think if you've had a dissection and you're walking around, you're living on, it's been a bonus, because it was more likely that you died at the time of the dissection than that you were saved. And so that, how can that not affect you?
Yeah, it does.
And change your way of approaching your life.
Yeah, it really does. And, for a lot of patients, and one of the reasons why Aortic Hope was created was because so much time was spent not understanding why I was having nightmares, why I was hearing things that didn't exist, smelling things. I had no clue. I thought PTSD were for war veterans. I didn't know, or people who suffered extreme sexual traumatic events. These things were happening that were not happening, but I would tell you that they were happening. I could smell, taste, hear things. And then I finally, almost a year later, went and saw someone. And then it was explained to me. And as soon as I started specific EMDR therapy, it was very soon after that the majority of my triggers went away. And I just remember saying that this can't be like this in a community. I know I'm not the only one. And when you realize how many other people just sit and suffer silently when they don't need to, there's nothing I could control. It's just how my brain reacted to being overloaded. That was one of the reasons why we're just really big into promoting and supporting everybody from a mental health perspective as well. So I'm glad that you forward everyone on and that you recognize that too, which is wonderful. All right, 2 more questions and then one final big one. People want to know, can they fly on vacation? It sounds so silly, but it's not, because the newbies that are new to this community are like, am I allowed to fly? And can I go someplace like the mountains in Aspen? And I will write back, there are patients that had a dissection and live with an aneurysm that live in Aspen. So I think you're going to be okay, but double check your situation with your physician. And that had to be told to me. And I was like, oh, yeah, I guess you're right. Somebody is living there right now with an aneurysm and they're fine. So what are your thoughts on that?
Okay, so mostly it's safe, obviously, to fly. And I think, I often think, well, why did this ever come up? Yeah. And it's, when you get on a jet airplane and you go up, the cabin is pressurized. It's not fully pressurized. And you probably see sometimes, if you take a plastic bottle or a packet of chips or something, you notice how they get so much bigger when you're up there. Yeah. So if you've recently had surgery on your chest and air has got in to somewhere in the chest, it's usually in the lung spaces rather than in the heart space, and it hasn't been evacuated yet, then that can be a problem, because you've got this pocket of air which is at atmospheric pressure where you had the surgery, and you go up in the air and it's not fully pressurized, and that thing can get bigger. So I think mostly this issue about flying has come about because of that. And so for the first few weeks, we don't immediately let patients leave the hospital and get on an airplane. We like to see them in the clinic and do an X-ray, check they haven't got any air pockets, and then they can fly. Right. The other thing is, when you fly, apart from it being generally super stressful getting through the airport and all that, is that the oxygen level in the cabin isn't quite what it is down on the ground, because it's not fully pressurized. That's so true. If you have a borderline cardiorespiratory function, then going up in the airplane could expose that. But
Mhm.
most people are not so tenuous that would expose them. So mostly it's very safe to fly
Okay.
sometime after you've had your surgery.
Scuba dive.
And then scuba diving is the opposite problem,
Right,
where the
exactly.
pressure
Let's
is
go in
all
the
on
wrong
the
place.
outside.
Yeah, yeah.
But the I don't think that the aorta and the various blood vessels are subjected to different wall tensions through the scuba diving. And I think it's reasonable to scuba dive, and there are patients who have had this sort of surgery and have been US Air Force jet pilots who have gone
Wow.
back to flying and subjected their aortas to these very high G forces and have been okay. So
That's
I think
crazy.
that domestic scuba diving and mountaineering is acceptable.
Oh man, I can't imagine. I'm told I can't even ride a roller coaster at Disney World. So yeah, no, I'll stick with that. My thrill days are gone anyway. Anything incredible and amazing happening at Cedars-Sinai in the future? Anything we should know about? And we're going to put information in case anybody wants to reach out to you in your clinic, but anything that's on the horizon that you're working on.
Yeah, so probably the biggest thing we're working on is AI in this area.
Mm-hmm.
And we have an enormous imaging database. And so we're using AI to try and better predict, well, first of all, to keep better track of our patients so that
Okay.
we're absolutely 100% secure we monitor each patient at the right time, but also to better predict when we could intervene. And especially if they're having imaging for other reasons, the AI is clever enough to be able to go and look at those images. And I really think this
Amazing.
is going to be an enormous area for the future, and it's going to improve patient care dramatically.
That's wonderful. That's wonderful. Joshua, any other thoughts, comments?
We have a few actually that are floating
Okay.
here. So LM San says, Dr. Catarino, what advice do you give to a patient who has undergone successful aortic surgery to repair an aneurysm at the base with the execution of the Florida sleeve procedure?
Okay. Well, I think that's a very good procedure. Very provides a great degree of protection of the aortic base, the root of the aorta. So, one of the issues with any aortic surgery is that we don't have a very good elastic prosthesis. All of our prostheses are like this. They're stiff material, and so we replace a segment of aorta which is elastic with a little stiff portion of medical graft, and so that transmits the pulse from the heart through the stiff portion. So your Florida sleeve will be, it's got this material around the native aorta, so it will make it stiff. It transmits the pulse to the next area. So I think you just need to have monitoring, not excessive, but monitoring of that distal portion of aorta to make sure that the pulse isn't transmitted to the next portion, which then dilates.
Thank you so much, doctor. Nina says, this makes me feel so good. I just had a visit with my thoracic surgeon, and he said these very same words. Then she said, amazing. I said, I'm an instant fan of this doctor.
I'm very pleased to hear that.
We love validating comments. That's wonderful.
Yes. Our very own Carl Hartman jumped in, and he says, heart remodeling after a type A dissection. Is it typical to have a heart heal over a period of years? Example 2021, extremely enlarged left ventricle, recovered to normal by 2024. Is this typical?
Yes, I don't know about typical. I think that's great news. And to some extent is expected. So a patient who had hypertension, which would cause a hypertrophied ventricle and also cause a dissection. Once the dissection was treated and the hypertension addressed, then the heart we call it reverse remodel. So the hypertrophy would diminish and the heart would go back to normal shape and size. Obviously doesn't happen in every case, but that would be our hope. And if it's happened with you. I'm really delighted for you. It's good news.
And thank you again for that, Doctor. Christina, one of our big fans here, says, last CT radiologist stated an enlarged heart. I am 10 years post type B dissection. New cardiologists didn't do his homework, so don't know if this is just enlarged within the last year. Is that bad?
So I think an enlarged heart always needs some further examination of why it is. So you really need to get to the reason for why is the heart enlarged and why has it become enlarged at this point. Type B dissection is commonly related to high blood pressure, and that may have been a chronic issue, but it sounds like the timing of this enlargement may not fit with the timing of the type B, but it's something which it's definitely worth investigating further, because there are good medications that will act to counterbalance that enlarging tendency of the heart and bring it back to a normal size.
Okay, thank you for that as well. Christina, I hope you can do something with that. Carl has a second question here. I get confused by all the terms for doctors. How do I differentiate vascular versus somebody just chatted. Oh, stop chatting. Vascular versus cardiologist, interventional cardiologist versus just cardiologist, cardiothoracic surgeon versus cardiovascular surgeon.
Okay. So vascular surgeons deal with the peripheral blood vessels, which do include the aorta, but typically they start taking over about here where the left arm artery comes off. So everything beyond the left arm artery going down the descending abdominal aorta, the legs, is typically managed by vascular surgeons. And everything from the left subclavian towards the heart is managed by cardiac surgeons. Most cardiac surgeons are trained as cardiothoracic, the thoracic bit being the lungs and the esophagus, but they mostly focus on cardiac. And then cardiovascular usually means a surgeon who's got training in both cardiothoracic and vascular. So they sort of bridge those disciplines. And then cardiologists are the doctors who look after the heart. And some cardiologists, there are lots of subspecialties of cardiology, but some of them are the interventional group who do the transcatheter procedures, put stents in. And they may get involved also in stenting of the aorta in different places. And this whole area has become much more blurred, with there being more stents available that can come ever closer to the heart. So there are more vascular surgeons now operating and intervening on the arch. And with the arch, you've got the blood vessels to the brain, the carotids, and the cardiologists are intervening increasingly on those blood vessels. So this area between the ascending and the left arm artery is often managed by a mixture of vascular surgeons, cardiac surgeons, and interventional cardiologists. And really in the best units, best what we call comprehensive aortic centers, all these people get together and they have slightly overlapping competencies and skills and experience, and together they're able to offer patients the most sort of individualized treatment and the most suitable treatment for their particular condition. So ideally, that's, one wants to be treated in one of these comprehensive aortic centers.
Are there ever an occasion where if you're doing surgery for, let's say, for a dissection where both a vascular and thoracic would be in the room same time?
Yes.
Okay.
Yes. I have a very good vascular colleague here, and we've often operated together in exactly those situations.
Good to know.
Okay, thank you very much for that as well. I'm going to try this name again because it's so challenging. Vijayalakshmi Nagaraj says, a person with a TEVAR procedure more than a year with multiple stents, do you need to take antibiotics before cleaning or any other procedures done on the teeth?
No, I think it's far enough away that you don't need to take antibiotics. And the reason for that is that your body covers those stents with its own cells, and certainly usually by 6 months, and certainly by a couple of years afterwards, your own tissue will line those stents, and they won't be exposed to any bacteria that got in the bloodstream from the teeth manipulations.
Roger that. Thank you very much. Okay, and one final question, and then there's just a bunch of thank yous. The final question that I have here is Nina asks, can you ask him why ibuprofen is discouraged, and
Yes.
what his thoughts on blood thinners, yes or nay?
I'm so glad that this is coming because I'm on Eliquis. We're not 100% sure, but pretty sure I'm not having AFib, but I have another arrhythmia issue. And I am so angry because Tylenol doesn't do anything. So I'm going to admit it. I've snuck an Advil because that's what works. And sometimes it's pros and cons on what something's giving me a lot of pain and making my blood pressure rise. I need to make the pain go away. I don't do it often, but I have done it. So I am curious to know your thoughts on why is Advil such a no-no, especially when mixed with Eliquis. But pain is the preferred thing we're supposed to live with. I'm sorry, that's how I feel.
So I think the main problem with painkillers like aspirin, ibuprofen, Voltarol, all these non-steroidal anti-inflammatory drugs, is that they cause a little bit of stomach irritation, potentially even stomach bleeding. And so that in combination with blood thinners can lead to big stomach bleed. Okay. And that is a problem. But I think, I think individual patients probably know if they take ibuprofen. I probably wouldn't advise using it every day, the full dose every day and using the blood thinner. But if you know that you tolerate ibuprofen reasonably well for the one-off when you have pain, you're going to use it for 24 hours, then I think probably you'd be okay even with the blood thinner using ibuprofen.
Yeah. Okay, good. So I made an executive decision for myself. But that's a good question because I think a lot of people are told absolutely no go. And to that, why no decongestants like Sudafed? When that is what's going to take away the head cold. Is Mucinex DM and there's Quercetin, but sometimes they don't work and you just really could use a Sudafed to knock it out. And we're told, no, there's no Sudafed.
I'm not sure what that is. There's sometimes drugs like epinephrine, so they're they constrict blood vessels. Okay. And that's what stops the congestion. But the same effect that constricts blood vessels also puts your heart rate up and your blood pressure up. And so I suspect you're being advised against that because maybe you have an aneurysm. So you think, well, we should avoid drugs that may cause a side effect rise in blood pressure. Right. I did listen to that. I'm very compliant, but the Advil, sometimes it's hard to be compliant. But don't listen to me. Nobody listen to me. I'm my own worst enemy and a rebel. Is there any other questions, Josh?
All right, let's go through some of these positive affirmations here. Sure. Josie Kyer says, thank you. I really like listening to Dr. Catarino. He's an excellent speaker and his explanations are so easy to understand. That's a great talent. I learned lots of new facts about aortic disease. Thank you so much for that. LM Sand says, thank you for your explanation, Dr. Catarino. We appreciate your knowledge. VG, who told me I can call him that or her that. Truly wonderful to learn so many details in such a short time from the renowned expert in the field. Thanks to the organizers. LM Sand says, thank you all for speaking about the PTSD aspect of these conditions. It's been most challenging part of managing through the years. Jeanette Hogan says, amazing information. This doctor is so interesting. I think so too, Jeanette. Jason S. jumped in to say, this is such a good conversation. I really appreciate Dr. Catarino, myself, and all the other contributors. Thank you again, Jason. And Tony Montana, who we haven't seen in a couple bits. Great to see a very talented British team at Cedars-Sinai. Go England, LOL.
Thank you very much.
That's wonderful. Well, I will just say thank you so much for joining us today. I'm so excited we finally had a chance to do this since you have come to the States. I know I've wanted to do this. I'm sure Shannon, who was wonderful in getting us together, has probably told you I have a lot of great ideas of things I'd love to see Aortic Hope and Cedars-Sinai come together on, and we'll discuss that further. But I really appreciate it. Like I said, there's nothing better for me than when I have an opportunity to actually learn something as well. That tells me a lot about our speaker and about the information, and you've heard it through the affirmation. So thank you again. And also thank you for being such a supporter of Aortic Hope. It does mean the world to us and to everyone in the community.
Oh,
Thank you.
Can I squeeze one last question in?
You can.
This is one I've never heard. So Tony Montana says, large weight loss, is it common after a type A dissection and taking beta blockers?
No, we're all striving for weight loss. I haven't come across that, other than that, somebody's had a big life event, and then that may motivate them to lose weight, lower their blood pressure, and live a more healthy lifestyle. But it's not a typical feature.
Okay,
Can I say thank you? Thank you to all of you who've dialed in and asked questions, and thank you to Josh, and very, very special thank you to Karen. And I really appreciate the energy that you exude and that you have put into Aortic Hope and all the work you do. It's very much appreciated from us group of physicians. We really, really appreciate you. Thank you.
Well, you are very welcome. And just to remind everybody, please click like. I know you said you liked it, but I need you to click like, and please share this because I guarantee you somebody out there will get something from this live event. And don't forget to click subscribe so that you're notified then next time we go live. And we'll have a lot coming for you in September for Aortic Disease Awareness Month. Thank you again so much for joining, and have a wonderful rest of your day.
Bye-bye, everyone.